So I run the brain injury program at Rusk Rehab Center and the University of Missouri. I take care of concussion patients all the way up to severely traumatic brain injured patients in the inpatient unit at Rusk. So concussion, when we talk about the different definitions, he's going to go ahead and play that video for me. We're going to have several different videos just of things to watch. You guys have all seen some terrible things. You can find it anywhere out there. Why is this such a big deal? There's a lot of different definitions out there, but really concussion, the definition has more to do with the pathophysiologic process that's affecting the brain induced by these traumatic biomechanical forces. All the different sources have different ones depending on what we're looking at different times. But really, we're just starting to understand the pathophysiology. A lot of that is out of some of the NFL stuff, and we'll talk about that here in a few minutes. So, what is the most common cause of traumatic brain injury? Traumatic brain injury. And we'll let you guys vote on this one. What do you guys think? When we actually look at it, when we study it, which one of these is the biggest cause? All of them can cause it. And there's problems with our statistics, but I want to see what you guys all think. So we've had several people in here study up a little bit, right? When we look at studies, it's falls and motor vehicle crashes. Very likely sports, it's not represented very highly. It probably is higher up there. It's because those severe and moderate to severe definitely outweigh. Those are easily tracked. Some of the tracking mechanisms we have for concussion is still in its infancy. We have quite a few concussions that are happening by other means. But the problem is we have to use ER data. So how many of you in here just personally have had a concussion? How many of you, keep your hands up if you actually went to an ER to have care? That's about right. So about half the hands come down. But when we look at the data, about 1.7 million present to the ER with a brain injury of some sort. And we're estimating that it's more on the lines of about 5 million that actually have this. And the majority of those are discharged the same day. And depending on the study, we're talking falls and motor vehicle crashes out of that group. Now, and is Dr. Dyke in the room? Not yet? Okay. He had a presentation too. I borrowed some of his information to try to make sure we all have all this cohesive, but 10% of all contact sports athletes yearly have a concussion. 63% of that is in football. 20% of football players per season will have a concussion. So what's the most common cause of sports concussion in the United States? And you guys can vote or you can just shout out. And we're going to see a lot of that, right? This is the United States. What do you think it is in the world? Soccer. And that's, as we see that, we will see soccer increase in the United States. And we have a couple little videos here, just as we're talking. Now, what do you think the most common cause in Canada is? It's actually football. So football, and I'm not anti-football by any means, if anyone who actually knows me, but it is our most common form of concussion. These are just brutal ones, easily found on YouTube. And we're going to talk a little bit about CTE here in a few minutes. And then obviously if you have kids playing soccer, this always makes you cringe. Soccer has its own inherent risks, right? And so rule changes, helmets, all of those things, there's only so much you can do. You're still going to have that potential for some of these injuries. So looking at the data from the Missouri State High School Association, you may be familiar with this. Just the sheer number of athletic reports just last year, it's about 3,000. And numbers of days of the sport was missed, 37,000 different days for just this related. About 3,500 days of class time were missed from this. And activities include other things outside of that. I think they actually include cheerleading in that rather than in sports. Those add to that. And then here's some of the head injuries by sport. Football football kind of outweighs that quite a bit. And then soccer is second, but it's a distant second still in Missouri. So what's going on in the brain? We won't bore you guys with some of the medical details of this, but just real quick, what happens to the brain at that moment of impact? You get bruising, and you get contusions, lacerations, which are bruising and cutting through the brain tissue. Normally, with a concussion, you're not going to see that unless you're in a severe brain injury. However, some of the bruising is occurring when we look at it under the best of circumstances. And then there's this traumatic axonal injury or diffuse axonal injury, because the brain is kind of gelatinous. It's not a very solid structure, and basic high school physics, right? Something that's in motion, going to accelerate and decelerate at different rates. We have different densities. You get a tearing motion in there. That is not seen on an MRI or CT. Most of the time that's thought to be what the cause is when somebody actually has a loss of consciousness. And then there's other vascular injuries and cranial nerve injuries. That traumatic axonal injury tends to happen in these areas. We can look at it if we were to biopsy somebody's brain, but MRI CT is going to show that, which is consistent with what we see in concussions. Usually this is happening where the gray and the white matter, for those of you that are neuroanatomically inclined, where those join. Secondary injury, most of these are going to be more in our severe injuries, but you will see some additional injury that's ongoing for about 14 days after we're going to talk about, including some edema and swelling in the brain. You can get infection, hydrocephalus. All of those things are bigger deals for our more severe, but increased release of some of these neurotransmitters. Basically, the brain is put into a situation where it's more susceptible to injury immediately after a concussion. And so our screen here is cutting off a little bit, but must you have a loss of consciousness to have a concussion? And this is a fallacy type 1, right? However, it's an older one, but there are still people out there who believe this. And I work with some in the state, so make sure you realize you don't have to be knocked unconscious to have a concussion. So what is some of that pathophysiology? And this are some of the things that have come out of the money studying brain injury from the National Football League and on down the line. So we have learned that what's going on in the brain tissue and the axons are stretching, not always breaking, and then that releases these neurotransmitters, causing these changes in the brain that eventually result in increased calcium throughout the brain. Lots of drug companies are trying to figure out how to harness this. We haven't been able to figure it out. And part of the reason is actually some of this timing. And on the left there, where it's kind of cut off, it's 0 minutes to 1 hour. Most of these are happening immediately after the injury. Well, you can't get a medication to be delivered early enough to prevent any of this. And if you knew you were going to hit your head that day, you wouldn't leave home, right? So most of the problems are initiated there, but continue for about 15 days. Now, what's our return to play protocols? Some of the ones that are out there. A lot of them are more on the 7-day range, right? Well, we'll talk about that. There's a political reason for that, but for you guys, then you need to decide what's best for your particular athlete. So on the field, a lot of you guys in here are going to be able to tell me better what's going on. I don't sit on the field. But obviously, what are some of the symptoms you're going to see of concussion? You guys can type these in. What are things that you would see and worry about in your athletes or your students that they might have had a concussion? Yep, vision, confusion, nausea. Yep, you guys are right on this. Headache. Memory impairment. Is everyone agreeing with this list so far? So a lot of you guys are very educated in here with what we have. That dazed look, unbalanced. Yep, that index of suspicion. There's quite a few things. Everything on here, you guys are absolutely right. A lot of people are putting headache, confusion, and a change. Really, oftentimes that's one of the main things, and I'm glad somebody mentioned that. They're different. Something is off at that moment. So excellent. You guys are all over that. So we're going to come back to it a little bit. Some of the sideline eval, maybe a physician, maybe an athletic trainer, you should be using some sort of standardized system like the SCAT-3. How many of you in here use the SCAT-3 as your sideline? Does anybody use something different? No? Okay. So we'll talk about that just a little bit. You guys are going to be experts on that. Involving that question, we're testing that memory, orientation, and some physical portions of it, and we'll review that here in a second. Loss of consciousness is one, you don't have to have it, but if you do, it's an obvious one that they are done, right? Post-traumatic amnesia, which is that momentary loss of memory. Memory loss in brain injury and concussion, it's not like in the movies when we say amnesia, where people pack up and move to Cleveland. It's where you're not forming new memory. So at that moment, they're just kind of lost in that moment. They don't forget who they were, who their parents are. They just can't recall memory for a very short period of time. And then the retrograde amnesia is they'll lose a few minutes before that. And then take their helmet, right? So the SCAT-3, you guys are familiar with this. We have the Glasgow Coma Scale, some of the things on there, but really we're looking at memory and then the subjective evaluation that we're trying to get. We want to look at the neck, and the balance is a big one, right? You guys were listing things. We had a lot of memory, we had a lot of balance, we had a lot of visual. Those are the things that are going to be your high yield evaluation at that moment. And then there is a child SCAT too. Basically, this is more or less just changes the questions. The questions need to be a little different. And so those are both out there. Balance error scoring system, our athletic trainers in here are going to be way better at than I am. And so basically trying to avoid the errors on this, and I actually make my residents do it, and they all fail if they're not athletes anyway. But it's good for them to see what this is. Clinical evaluation, what am I going to do? Shortly after that, it's most useful shortly after, we want to look at their overall neurologic evaluation. It should be normal. If it's not, that may mean that they're going to gives us some pretty good idea with that. Occasionally with athletes, I will have to get a CT of their head if the impact is bad enough. I showed you guys some videos. You guys probably had some imaging. Those were pretty nasty ones that were there. C-spine evaluation. And then you guys got a lot of this already. Signs and behaviors, dazed, confused, difficulty remembering. They're forgetting things. They forget ask them what the score is. Where are they playing? Where did they play last week? And show behavior, personality changes. Then symptoms, headache, nausea, vomiting, balance, dizziness. These are the ones that are a little easier to pull that athlete out of a game, right? Concentration, memory problems, doesn't feel right. And then following this, now we've got this concussion. What are some of the things that may follow behind it? Well, just like any of us, well, what makes them human? What makes them there? They might start having some poor academic achievement, depression, social disengagement, vertigo, headaches, disturbances, anxiety. Those type of things follow this but are directly related to that head injury. So those of you that are teachers or therapists, you may see this on down the line even when they're back to their play. When do we start calling it post-concussion syndrome? It depends on the source, but it's usually about 3 months out. We will see things like any of the others, the headaches, sleep issues, concentration, memory, and depression. Those are some of the changes that I see. Usually it's parents saying something's just off since we had this concussion. Neurocognitive testing, I'm trying to run through a whole bunch of things here with you guys. Neurocognitive testing and neuropsychologic testing, something that's mentioned quite a bit, the impact testing, all of that. This is not a diagnostic tool. It does not tell us that you had a concussion. It can tell us some tracking injury and recovery. There's some evidence, possible baseline, but the more we dig into it, the more we're realizing it doesn't have as much value as we had hoped for. It depends on what you do. Like my Division I, the SEC, they do use testing, and so we do that at the pre-participation and then also additional injuries beyond that. So there is limited support. It is out there. In high school level, is anyone using this as a tool at all, the impact testing? No, it's much more at the in high school? Okay, good. Are you using a pre-participation as well? Okay, that's good. There aren't too many that are doing it yet. This is a typical for a room. 1 or 2 usually is what we've got. And it's been plus or minus. Have you felt it's been a good tool so far?
I mean, I'd have to talk to my athletic.
No, you're fine. I didn't mean to put you on the spot. I was just curious because it is really, it's more on the controversial end with that. It makes us feel better to try it, but we haven't decided yet whether it's 100% a good tool. So for you guys, just keep it on the radar and know that this is kind of one of those things they're looking at more and more. So neuropsychologists, however, alone, neuropsychology, speech-language pathology, short, long-term goals, relearn cognitive, some of this can be done with occupational therapists and speech-language pathologists as well. When these things become persistent, neuropsychology as well as the neuropsych testing becomes more important. For you guys as coaches, these are the kids who they're not getting back. They're not still there and they're having ongoing problems. They're usually beyond that 3 months. That's when neuropsychologists' actual intervention tends to become more important at that time. Second impact syndrome, this is the one we use as a threat more than anything, right? And it is a very terrible thing, high mortality and morbidity from this. It's the scary one. That brain, remember we have 14 days, that's how long they're susceptible for this second impact syndrome. That's that second injury on top of a first one. Oftentimes what I do with this is you do want people to avoid it. It's pretty, but this is the one we're talking to parents saying, we can't have you coming back in this quick. And so that is a terrible one, but luckily it's very rare. Now, CTE, chronic traumatic encephalopathy. Who in here saw concussion? Handful? Okay. That's where most people get some of the information. And just so you know, Dr. Malu is a weird bird. He's a very brilliant man, and he's a little odder in real life than he is in that movie, but he is brilliant and was able to look at some of this. So we're going to talk a little bit about where that is. Combination of cognitive, motor, and behavioral problems pathologically looks like Alzheimer's. This is not a new syndrome. We changed the name of it. Does anybody know where we saw it in the past? Early 20th century? Shell shock in World War I, same pathology, and boxers. Dementia pugilistica is an very similar type of pathology. We're now discovering that a lot of this pathology is the same when we dig back in. But it looks very much like Alzheimer's disease for these guys. So chronic traumatic encephalopathy is unavoidable if you have enough concussions. True or false? Anyone? What do you guys think? Heard a couple of trues and I heard a false. And how many of you in here think this is a trick question because we don't quite have enough information? We don't, but what we do believe when we talk about CTE, this is one of those things that now we're actually studying it a bit more. The average lifespan of an NFLer is actually longer than the general public. The majority of former NFL players live a longer life and don't have this problem. So we do not believe that this is true at this point. For the ones who do, it can be a devastating effect. But what we're trying to figure out is who's susceptible and who's not. The jury's still very much out on this, but we think that this is very much false. And everything that's talked about with it makes it seem it's a very terrible thing, but it is still on the more rare end. So this is Mike Webster in 2002 at his death. This is where Dr. Amalu, the first of the brains that he worked with. And so died from heart failure, from drug use, but had major depression, memory loss, basically everything that looked like Alzheimer's, psychiatric problems. And his post-death diagnosis was that chronic traumatic encephalopathy. If you guys watched the movie with Will Smith, you know that he's the one who started that. The next brain that Dr. Amalu looked at was Andre Waters in 2006. We're going to run through some of this because the timeline's important because of the sport and how we have got to some of our protocols. And Dr. Amalu at that time, the brain would look like an 85-year-old man when he was 44. So the NFL did a study in 2009. And actually, it wasn't the NFL. It was Dr. Weir at University of Michigan did a phone study. And players that were retired age 30 to 49 had 19 times the national average of dementia-related diagnosis. And those over 50 had 5 times the national average. So that was what really, these events kind of kicked this off. The NFL responded and discredited the previous studies and formed their own study that said there was no relationship. The NFL Players Association followed that up and formed their own committee and actually met with Congress. Yes, your tax dollars at work. They were meeting with Congress on this in 2009. And essentially, the Congress completely discredited the NFL's independent study as fabricated and not accurate, and started challenging Roger Goodell at that time with the concussions. And this really kind of got things rolling from there a little bit. We did have NFL rule changes in 2009, and that was the first time in 2009 that players could not return to play the same day with a concussion. A lot of these things started trickling down then all the way to the high school level starting in 2009. And so we had to be fully asymptomatic, normal neuropsychologic testing, and be cleared by an independent neurologic consultation on the sideline. And players were encouraged to fully disclose any symptoms. With some of the rule changes, what do you think happened to the incidence of concussion? It actually went up. Why? We think there was reported more. So every change actually was met with that. This is going to be a little harder to see in here, but out of those meetings, the NFL was forced to put posters in the locker room. That seems like very little, but it was enough to educate the players, and that went up. They also gave $30 million donation to the NIH. That actually money showed some of the research that we talked about where we have the pathophysiology. 2011, NFL moved the kickoffs by 5 yards. That actually increased concussions. Why? We think it's more reporting. It actually decreased some of the high-speed collisions, but it did change that. 2012, like I said, they increased by 14%. That was when we had more brains available to look at for CTE. Former players were encouraged to do so. Then in 2013, the Players Association put $100 million into this and banned the crown of helmet tackles. And then the settlement for the NFL at that point in time, $765 million to former players, but had to admit no wrongdoing, and future lawsuits can be brought toward the NFL. And they never had to do that. So what happened after that? Well, the NFL got busy with other things, and we've had kind of a quiet time here with that. And then concussion came out. That actually gave us a little bit more chance to reevaluate this. Now, do they have to die to have some problems? I'm not really a Roethlisberger fan. You know, he had this, but maybe he was just an idiot. And this guy probably really is an idiot. And so, are those related to concussions? We don't know. But it's not always that mortality. It's just you got to think about the morbidity, and so the safety of given. So which of the following is true when we're talking about facts or fallacies? Which of these is a real thing? And so blows to the head, all blows to the head result in the concussion. The harder hit result in greater risk of concussion. Head injury is the same as brain injury. And some concussion can have no long-term sequelae. And honestly, I forgot what the last one was. Can you read that for me in the back? We can't see the whole thing. Oh yes, helmets have greatly reduced the risk of concussion. So which is actually true? And this one's a little bit harder, and we're going to talk about each one of these a little bit. Okay. So no one voted for A. Harder hits result in greater risk of concussion. Not necessarily true. It depends on the vectors that are going on. So that would be true if it was all hits directly to the head, would result in that. Head injury is the same as brain injury. So is that true? It's not. That one's not true. You can have an injury to the head that does not result in some sort of a brain injury or concussion. Some known concussions can have no long-term sequelae. That is very true. So it's something that you do need to be aware of, that when you're talking to these people, especially parents, when they have one concussion and they are having a complete recovery, that they could have a long normal life and never have any sequelae. That is a possibility too. We talk a lot of doom and about concussions and head injuries with families, but the world isn't over if you do get one. And helmets have greatly reduced the risk of concussion. Very few of you actually put that. They have not. They have reduced neck injuries, and there are studies ongoing, and there are pressure monitors in our Mizzou football players right now. And they're part of a bigger study too, trying to see, well, what do the helmets do, what materials are better, what actually dissipates that. But as of right now, they have not reduced the rate of concussion. So how do we manage them? Take them out of the activity, right? Remove from competition if applicable, restrict physical activity, neurocognitive rest. A lot of you in here are going to be even better at this and do a great job. The athletic trainers and coaches are on the front line, right? But it's really a whole team. And so at the top of this is that patient. And then you have the doc and the parents and the coaches and the ATCs and the therapists, neuropsychology. Everybody needs to have a role in this. And you may or may not need therapy and neuropsychology depending on where they're at. But they play a valuable role in that recovery depending on where they're at with this. Physical rest. How long do we do physical rest? Anybody in here want to shout out? How long do you make them actually just get away and physically rest?
1 week.
About 1 week, right? No more than that. There's actually not any studies that say anything more than that. Usually asymptomatic within 7 days, right? So cognitive rest, how do we make them cognitively rest? This one, you have to be very specific in our society, right? No cell phones, TVs, all that stuff, because some kids may actually have more stimulation at home than they do at school. So you need to be very specific with it. Does anybody know what they do in the National Hockey League for this? Because those athletes are kind of their property. They put them in a hotel and cut the power. That is their cognitive rest. And so that is allowed with them, but they're a professional athlete. It would be kind of barbaric to do to a high school student, but just realize that you need to have some of that decreased stimulation to try to get by from this. Duration is variable. Really, we're talking about within 1 week again. So kind of hovering around that 1 week mark, right? Symptom management, headaches. Any PTs in here? PT? All right, don't overlook the myofascial component of a headache. And so a lot of these headaches, it's not just the brain hurting and everything else, it's because their head got rattled around. And they have neck pain and neck musculature. A lot of the times we can decrease their headaches by treating that part of it. Sleep disturbance is one I'm a little more aggressive with treating. And I don't use pharmacology in everybody, but we definitely try to make sure we get that. Worsening symptoms or persistent symptoms, we need to make sure we're managing. And again, don't ignore psychological and emotional symptoms. Oftentimes that may be there just from them not being able to do what they want to do. Zurich guidelines 2008, more conservative. We still follow this for the most part. This is a 7-day return to play. Who do you think this was developed for, 7 days? We already said this was developed for the NFL. The NFL did not adopt this. And so a lot of other organizations have adopted this, but that was who this was for. There is still some susceptibility for second impact 15 days out. Does that mean all your athletes need to be out 15 days? Not necessarily, but realize that what this protocol was, it does have political issues with it too. And that was so that Tom Brady can play in the Super Bowl, right? And so that's what this is, the type of program, but they did not adopt this. So each one of these is 1 day rest until asymptomatic, 1 day of light aerobic exercise. We drop back a day. A lot of you in here are going to be familiar with this. trying to get back to that return to play. If I have a high school or a kid and they're having this, if they haven't had 4 or 5 days lead time, which would start this a little bit later, I usually will do this each step 2 days, just to kind of do that. If they have a state championship a week later, then maybe we're a little more aggressive with this and see, but you want to make sure you're being safe for your athlete. Pharmacotherapy, I only consider if they're becoming persistent and problematic at that point in time. Neuropharmacology, I will remove meds that are bad. There are some that we can use for this. This is for the really badly injured ones that are just persistent, but we're going to burn through it. And we have several different clinics here in town. Mine is with a neuropsychologist and an occupational therapist. Return to learn, I think you guys are going to talk about that a little bit later, but I'm not going to go into that now. Prevention, how do we prevent? The one thing that has been known to work is the one that's highlighted in red. Education actually is our best preventative. We would like to say helmets work, not really. Mouthpieces really don't do anything but protect your teeth a little bit. Rule changes have had some effect, but really education is a big deal. And then now with the CTE scare, there's more talk of age limits on type of contact. How young do we let kids start tackling in football? Youth hockey has rules on when they can start checking. They can't start checking until high school. So some of those things are being looked at. And then retirement. I do have to retire some athletes, even high school age, when they've had multiple concussions. And just the last month, I had a girls rugby player who has had 7 concussions in the last year and a half. And that is a time when you have to have these discussions. There is no guideline for it. So I'm happy to talk to anybody after about how you do that, but when you start having more and lighter injuries or promoting concussion, that's when you start thinking about it.